What's up, Ninja Nerds? In this video today, we're going to be talking about chronic kidney disease, also known as CKD. Again, this is part of our clinical medicine section. If you guys are enjoying these videos, they make sense to you, they help you, please support us. You can do it a couple different ways. 1, hit the like button. 2, comment down in the comment section. And 3, even subscribe. Also, for your guys' benefit, down in the description box below, there's a link that goes to our website. On our website, we have much more to offer that I really think would be of benefit to you. Things like really comprehensive notes, illustrations, and lots of questions to really test your knowledge for some good spaced repetition. So go check that out. All right, without further ado, let's dive into CKD. All right, my friends, so we're gonna start talking about chronic kidney disease. Now, when we talk about the pathophysiology behind this, it's a little bit different from acute kidney injury, right? So acute kidney injury defined as like an injury to the kidney that led to an abrupt rise in the serum creatinine, right? And that usually happens in less than 3 months. Chronic kidney disease is you need to find the chronicity of this. So there's progressive loss of renal function. And this renal function is oftentimes defined in 2 different ways. One is that there is a progressive reduction in the GFR, all right? And this is referred to as the glomerular filtration rate. So there's a progressive reduction in the GFR. And oftentimes for this, it really has to be for 3 or more months to really kind of like fit us into the area of having what's called chronic kidney disease. So this is one way that we determine that there is a reduction in the renal function. Another way is that there is an increase in what's called proteinuria. And that means that you're losing lots of proteins into the urine. But the most common one is going to be what's called albuminuria. And funny enough, this is actually the strongest predictor of prognosis within CKD because it turns a lot of like cardiovascular risk when it comes to albuminuria. Now, these are the 2 ways that we look at a patient having CKD. The most common one is a reduction in the GFR. So this is a concept of renal function. Albuminuria is more particularly indicative of chronic injury to the kidney. And so these are 2 important things that determines that there's kind of a disruption or a reduction in a patient's renal function. Now, the question that you need to start asking is, why is there a reduction in the GFR? Why is there an increase in the amount of protein that's being lost into the urine? Now, one concept behind this is that there is what's called glomerulosclerosis. So a patient oftentimes experiences something called glomerulosclerosis, and this glomerulosclerosis leads to progressive loss of nephrons. And with those progressive loss of nephrons, that's where patients start to experience this reduction in renal function, such as the decrease in the GFR and the increase in the albumin. Because nephrons, you have to remember that these little puppies right here, these little guys here, there's 1.2 million of them in each kidney. So if I lose multiple nephrons, I lose the structural and functional unit of the kidneys. So when there's increasing glomerulosclerosis, there's increased loss of nephrons. And that increase in the loss of nephrons is what leads to these patients experiencing a reduction in the GFR and an increase in the albuminuria. Now, let me explain a little bit more about this. Glomerulosclerosis is oftentimes, I'm going to represent this in kind of a pinkish color. You're getting a lot of fibrous tissue, a lot of inflammation, a lot of kind of thickening, particularly of the glomerulus and around the Bowman's capsule. Well, why is that important? Well, when you think about this, when you have all of this, this is usually due to these cells called mesangial cells. And mesangial cells, what they do is they secrete what's called an extracellular matrix. And that extracellular matrix can thicken up this area here. Now, let's explain why this is important. So if I start having a lot of glomerulosclerosis, so I have lots of thickening and fibrous tissue and inflammation kind of going on around this area, guess what this is? This is my filtration barrier. And so now I have a thickened glomerular basement membrane. That's going to alter my filtration process. And so what's going to happen is I'm going to notice a reduction in my ability to filter waste products like urea, creatinine, water, potassium, all of these things from the body. And so because of that, that's where the patients will start to experience a lot of complications. So as that GFR starts going down and down and down, a lot of these things that are supposed to be moving through the glomerulus and getting filtered out don't. And so as a response, what we start to experience here is these patients experience a increase in some of the waste products that we can measure, such as their BUN, their creatinine, their potassium, their water, their acids, so many things. So we see lots of complications. Again, things like an increase in BUN, increase in creatinine, an increase in the potassium, an increase in the protons, and on top of that, an increase in things like sodium and water. And this can lead to complications such as uremia, hyperkalemia, acidosis, hypervolemia. And so we see a lot of these things starting to occur. And so this is a response of CKD complications, is as that GFR reduces, you lose the ability to excrete these substances, right? So that's the concept, is that there is a decreased excretion. So we now kind of have an understanding as to why this is so important. So if you don't excrete, decreased excretion of waste, you're going to have these things building up within the bloodstream, right? So that's why GFR is so important. And if we have lots and lots of glomerulosclerosis here, so here we're going to have glomerulosclerosis, that is what's really interfering with that filtration membrane. Okay, the other concept is, how does this glomerulosclerosis, right? We know that it's going to lead to a reduction in GFR. On top of that, this glomerulosclerosis is going to start causing a lot of problems. And what happens is it alters the ability of lots of tubular cells to start functioning. And so that's where we start to experience this loss of nephrons. But here's the other concept. As patients start to experience glomerulosclerosis, one of the first things, the earliest indicator of kidney injury, the earliest indicator is oftentimes albuminuria. So as patients start to experience things like glomerulosclerosis, and other complications, such as just lots of inflammation, particularly of this nephron, what starts to happen is it alters the permeability of the filtration membrane. So now there's more permeability. If there's more permeability here, because of this chronic inflammation and glomerulosclerosis, guess what starts kind of leaking out? Proteins, especially albumin. And as albumin starts to leak out into the urine, this is where patients start to experience what's called heavy albuminuria. And so whenever there's lots of albumin present within the urine, what happens is this leads to a couple different concepts here. And so whenever there's increase in albuminuria, what we find is that as a result of that, these patients start to experience some pretty nasty complications as a result of that increase in the albuminuria. And one of the biggest things is increased risk of cardiovascular disease. And we will talk about this when we get into the complications. The concept behind this could be a couple different fold, just to kind of prelude you into that. One is that as albumin levels in the blood start to drop as you put them into the urine, your liver starts increasing the synthesis of lipoproteins like LDL, VLDL. So it increases the risk of atherosclerosis and cardiovascular events. On top of that, whenever there's all of this inflammation and glomerulosclerosis, it actually causes a lot of these things to cause endothelial cell dysfunction and lots of cytokines to contribute to this as well. So that's the concept behind this. But this is the big thing to remember, is as I start to cause glomerulosclerosis and chronic inflammation, I will start to see eventually destruction and loss of function of the components of the nephron. And as I lose the function of the nephron, I will start to see a drop in the GFR and an increase in the albumin within the urine. And again, that is the concept. But here's what you got to start asking yourself the question. What is driving this glomerulosclerosis? And oftentimes, more than not, there's specific cells in this area. I'm going to represent them right here in black. And these are called your mesangial, or your mesangium, your mesangial cells. These things are what are secreting extracellular matrix. So they're the ones that are pumping out this extracellular matrix that is contributing to this glomerulosclerosis. You just then have to ask yourself the question, what's stimulating the mesangium? Oftentimes, it's chronic inflammation. Another one is it could be due to ischemia to different parts of the nephron. And sometimes transient high GFRs can also do this. So that's what I want you to start thinking about. So now what we're going to do is we're going to say, okay, we know that this is due to glomerulosclerosis, loss of nephrons. As you lose the nephron function, one of the biggest things is the loss of GFR, leading to complications and an increase in the amount of albumin lost into the urine, which increases the risk of cardiovascular events. Now I want you to say, what causes the mesangium to increase glomerulosclerosis? That's where we get into the causes. The most common cause of glomerulosclerosis and loss of renal function in CKD is diabetic nephropathy. It often accounts for about 40, sometimes 45% of the cases. So whenever somebody asks you what's the most common cause, you are going to say diabetic nephropathy. Now, what's the reason for this? It's diabetes, right? But what's really the complication with diabetes? It's when the patient has chronic hyperglycemia. So whenever patients have chronically elevated glucose levels, and really there's a lot of different ways that we can measure these glucose levels. We can do random, we can do fasting, we can do oral glucose tolerance tests, but the best way to determine a patient's likely kind of glucose levels as chronicity is hemoglobin A1C. And so if I see a patient who has a hemoglobin A1C that's greater than or equal to 6.5% despite all therapies, that's telling me that they're not controlled. So if I don't see control, this is oftentimes the most common reason. Now let's think about this. Okay, here I'm going to represent a little glucose molecule. So here I'm going to have a lot of these little glucose molecules. Okay, if I have these glucose molecules and I have lots of them, guess what they do? They like to bind with proteins. And so they bind with proteins without the presence of an enzyme. So now what I'm going to do is I'm going to represent here, I'm going to have kind of, let's say, my glucose molecule. And I'm going to have this bound to a protein. So now I'm going to have this bound to a protein. This is called non-enzymatic glycation, right? So non-enzymatic glycation leads to glucose binding with proteins, leading to glycoproteins. Guess what these things do? They go and they deposit right into the efferent arteriole. So they're going to deposit right here. When they deposit into the efferent arteriole, this is where we start to experience a lot of disease. And that's really the problem here, right? So we're going to stimulate what's called non-enzymatic glycation, which is a glucose molecule binding with different proteins. Once we get these, they deposit into the efferent arteriole. Why is that a problem? Well, let's represent this. Let's say here we get all these depositions here. And as I start depositing, what do you start noticing about the lumen of the efferent arteriole? It gets narrow. As I narrow the efferent arteriole, it makes it harder for blood to leave the glomerulus. So blood's supposed to come here and get filtered out, and then it's supposed to leave. But that's going to be impeded in some degree. And so what that's going to do is that's going to increase the back pressure in the glomerulus, which is going to increase the glomerular hydrostatic pressure. So it increases the intraglomerular blood pressure. And what that does is that causes kind of a weird thing. What do you start doing? If the pressure's high, the hydrostatic pressure's high, your filtration goes up. Zach, wait a second. You just told me that CKD is due to a low GFR. Watch this. Their GFR will go up, but it's transient. So they'll have an increase in their GFR, and we call this hyperfiltration. But this, I'm going to write this down here. This is transient, my friends. What that means is this won't last long. So what's going to happen is that those little peckers here, these little mesangial cells, these little puppies here are going to be like, oh heck no, we ain't going to tolerate that high GFR. And what happens is it tells the mesangial cells to start making an extracellular matrix as a protective mechanism. So now the mesangial cells, all right, I'm going to start putting down the matrix. Cells excrete an extracellular matrix. And now look what happens. As they do that, they start laying down fibrous tissue, connective tissue. They contribute to a lot of inflammation. And what does the glomerulosclerosis start doing to the filtration membrane? It affects it. And so now as a result, what am I going to start seeing? I'm going to see glomerulosclerosis. And as I see that glomerulosclerosis start to occur here, and this thing gets really, really messed up and thickened and thickened and thickened, what's going to happen? My GFR, as a result, is going to start going down. And so that's what we'll see is that as glomerulosclerosis goes up, the GFR goes down and the albuminuria goes up. So that's the concept here, is that this GFR will then start to reduce. And on top of that, you will also start to experience more protein that's getting lost into the urine. So you're also going to have more protein being lost into the urine. And that's going to be albuminuria. And that's the concept. That's what I really want you to understand. Now, the biggest thing here is that albuminuria tends to be the heaviest in diabetic nephropathy. So proteinuria or albuminuria oftentimes is an early indicator. This thing might actually become more evident first before a true drop in the GFR in patients with diabetic nephropathy. And that tends to be a very unique type of thing. So since diabetic nephropathy is the most common, look for the albuminuria. It may start to become more present as compared to the true drop in the GFR. Now, this is what I want you to understand, is that we're going from this process to this process that's leading to that reduction in the GFR. What about hypertensive nephropathy? This is the second most common. So this is the second most common. The other thing for this one is that I think it's within the name. So this one counts for about 45%. This one's probably somewhere around 30 to 35%. So that's a pretty good, when you think about it, these make up most of the cases of patients who have CKD. But it's pretty simple. I don't think it makes it too hard, but it's usually patients who have chronic high blood pressure. And we define that as being what? Greater than or equal to 140 over 90. So when patients have chronically elevated blood pressures, greater than 140 over 90, or they're not really controlled, this can lead to that. How? All right, let's say patient's got high blood pressure, right? So they're just, I don't know, maybe they're just eating lots of salt, or they have some type of genetic problem, whatever it may be. They're just not taking good care of themselves. When that happens, the pressure that's going into the glomerulus and via the afferent arteriole, you got different sensors, man. And they're like, okay, first thing they notice is that we got to increase the GFR, right? So they start increasing their GFR because of the blood pressure. What happens is whenever the blood pressure is high, the natural kind of like mechanism, because of the sheer stress from that hypertension, is to thicken the afferent arteriole. And so look at this puppy. This thing comes super thick. So thicken, right? So now, as a result of that high blood pressure, I'm gonna see a thickened afferent arteriole. So this one was thickened in the efferent. Now we're gonna have a thick afferent arteriole. What that's gonna do is if it's thicker, it narrows the lumen. Now here's why it's important. When you narrow the lumen, you reduce the amount of blood flow coming into here, right? So that's naturally, that's gonna lead to eventually a reduction in the GFR. So, right, what you're gonna notice is you start to narrow this, you're gonna start leading to a reduction in the amount of filtrate that's actually gonna be, the amount of blood going into the glomerulus. So that naturally will start dropping the GFR. But here's another thing. The thickened afferent arteriole leads to less blood flow going through the glomerulus, but also it leads to less blood going via the efferent arteriole. And guess what this does? It goes and supplies oxygen to the tubular cells. And if I'm not giving this, guess what I'm not delivering to these tissue cells? Oxygen. If I don't deliver oxygen to the tissue cells, they start to undergo ischemia. So what I notice here is that this thickened afferent arteriole does two things. It starts to cause ischemia to the nephron and causes a decrease in the GFR. All right? So it increases ischemia and it decreases the GFR. The ischemia is what stimulates the mesangial cells. That's what stimulates them. So then the mesangial cells are like, oh, heck no. And they start responding to the ischemia. And they say, all right, I got to start kind of helping out, fixing some of this tissue, kind of trying to fix the inflamed and injured area. And so that's what it'll do, is it'll stimulate the mesangium. And then the mesangium will excrete an extracellular matrix. And when they excrete that extracellular matrix, that's what leads to the glomerulosclerosis. And that's what leads to primarily a significant reduction in the GFR. There will be albuminuria, but it won't be to the degree that you'll see in diabetic nephropathy. So again, this will then stimulate the mesangium, they'll increase their glomerulosclerosis, and this will result in a progressive drop in the GFR. So that's the concept here. The ischemia is the primary stimulator of the mesangium, and it says, all right, we ain't gonna play this game, all right? So there's ischemia to the tissue, and as a result, it tells the mesangium, start laying down that protective extracellular matrix. And as it starts to do that, that's when we get that thickening of the membrane, we get thickening of this area, and that thickening here does what? Makes it harder for the filtration process. Also alters some of the actual normal filtration barrier. And so from this, you're gonna start seeing the patient's GFR start to drop, All right, and so that's what we start to see here, and you may again see some degree of albuminuria, but you're probably not going to see it to the degree that you'll see in diabetic nephropathy. All right, so we know the mechanism here is thickening of the efferent arteriole, leading to a back pressure, and then the mesangium responds and then lays down that extracellular matrix. This one is the blood pressure thickens the afferent arteriole, reduces blood flow into the glomerulus and reduces the filtration, but on top of that also causes ischemia because I'm not getting as much blood flow going into the glomerulus and then out of the efferent arteriole, and that'll lead to ischemia to the tissue. All right? Now, the next concept here and the last one is a patient who has glomerulonephritis. This I'd say would be like the third most common, maybe 10-15% of cases. There's a lot of different things for this, but we're going to dedicate most of this to the actual glomerular diseases section. But we can see this with a lot of different nephrotic and nephritic syndromes. We can see this particularly in things like membranous nephropathy, membranoproliferative glomerulonephritis, focal segmental glomerulosclerosis. These are some of your nephrotic syndromes. Whereas the nephritic syndromes, you may potentially see this in things like lupus nephritis, right? But it's more things that are usually chronic injury that can lead to potentially chronic kidney disease over multiple evidence of chronic injury to the glomerulus. Oftentimes with this one, the biggest thing to remember is that they have lots and lots of inflammation. Their primary trigger here is that these patients have significant amounts of inflammation, and it's just repeated bouts of inflammation that involves the glomerulus. And as you start to do that, that inflammation it'll naturally start to stimulate the mesangial cells, and it'll also cause these mesangial cells to start laying down, yes, the fibrotic tissue, but it'll also cause a lot of thickening of the glomerular basement membrane. And so a lot of these things will start to cause, again, a thickening of the filtration barrier. And as you thicken up that filtration barrier, what are you going to notice? You're going to notice a drop off in the GFR. So again, this part will be altered because you're thickening this area up. All right, so increased inflammation will do what? Stimulate the mesangium, and they will excrete an extracellular matrix, which will lead to glomerulosclerosis. And over time, we'll see that these patients will have a drop-off in their GFR. So that's the concept here, is that this will really induce this process, thicken this area up, and as you thicken this area up, you will start to notice that these patients will experience what? A drop-off in their GFR. All right? And again, the concept here is the inflammation from all of these immune complex mediated or multiple different types of mechanisms that we'll discuss in the glomerular disease section. It's really going to end up causing the same concept, thickening this barrier here. And if you thicken the barrier, you have a thicker barrier which I have to filter things across. That's a pretty common sense thing that it would lead to a drop off in the ability to filter things across the glomerulus. And that's where we'll start to see the complications in these patients. All right. Also, big thing for this one is they do happen to have very, very heavy proteinuria in these particular patients. So I would watch out because these patients from their glomerulosclerosis and lots of inflammation oftentimes experience a heavy amount of albuminuria or proteinuria. All right. And there's other things that we utilize to help us to think about this as a potential cause, especially the presence of hematuria and red blood cell cast, which we'll get into a little bit later. But this is the concept that I want you guys to start thinking about when we talk about CKD. I know it's loss of nephrons due to glomerulosclerosis. The glomerulosclerosis thickens the basement membrane, also starts thickening the glomerular filtration membrane, it makes it thicker, so now I have to travel fluid across that, a thicker distance. It's going to take much more effort, and I'm not going to be able to filter much across. GFR will drop, complications will arise. The other thing is that as you start to have inflammation and a lot of glomerulosclerosis, it alters the permeability of the filtration barrier and can lead to protein being lost. That's the concept I want you to think about. The things that progressively cause glomerulosclerosis: diabetes due to chronic hyperglycemia causing efferent arterial thickening, hypertension causing afferent arterial thickening, and then lastly, chronic inflammation in the scenario of chronic glomerulonephritis. All right, now that we've established our causes and patho behind this, let's now say, okay, a patient is experiencing CKD, they're experiencing a drop-off in their GFR and an increase in their albuminuria. What would that look like if it continues to get worse? All right, my friends, let's now move on to the complications. We understand now that as the drop in GFR starts to occur, as it progressively gets worse, we're going to start seeing a drop-off in the ability to excrete waste products, and that's where complications start to arise. Oftentimes, CKD is pretty much asymptomatic, and they don't really present with any very obvious signs, but as the CKD progresses to like stage 4, stage 5, which we'll talk about in the diagnostic section, that's when we start to see these patients having a lot of waste products and they start to have complications. And you have to be able to recognize this so that you know how to manage them appropriately. So the first one is metabolic acidosis. We definitely can see this again. I would say that it's at those later stages. The concept behind this is actually pretty simple. It's just like in a patient who has AKI, that we're supposed to be able to filter things across, things like protons, right? So that's definitely one thing that you should be able to do. But I'd say the biggest one is we're supposed to be able to filter bicarb, and we're also supposed to be able to have things like protons that we excrete. And then on top of that, we're also supposed to take the bicarb that we filter and reabsorb it. So we're supposed to be able to excrete protons and then reabsorb bicarb. If you lose the ability to reabsorb bicarb and secrete protons and filter off protons, guess what's going to happen? Well, the first thing that's going to happen is the protons in the bloodstream are going to go up, and the bicarb in the bloodstream is going to start to go down because we're not reabsorbing it, and then we're not getting rid of the protons. So protons go up, bicarb goes down. This is a recipe for the pH starting to drop. And so both of these things are going to naturally cause the pH to start to drop. And since this is due to a bicarb and proton problem, that's a metabolic acidosis. Oftentimes, this is usually an anion gap metabolic acidosis, especially as you start getting what's called uremic acidosis, where there's a significant impairment in renal function. So here's what I want you guys to remember is that this is usually the issue, all right? Now, the problem that exists here is that as the pH starts to go down, and again, a lot of protons being accumulated, one of the things is that these high protons, they stimulate these little receptors called chemoreceptors. And so these chemoreceptors, they're located, kind of in the carotids and in the aorta, and they respond to acidosis. And whenever there's a significant enough acidosis, it can stimulate those chemoreceptors. And what this will do is this will tell our sympathetic nervous system, our respiratory center, like the ventral respiratory group, to become super activated. And so what it'll do is it'll increase the respiratory drive. And now you're like, okay, what the heck does that mean, Zach? We're talking about CKD, not the lungs. It's going to send more signals via the phrenic nerve and the intercostal nerves to your lungs and cause them to contract faster and to have you breathe faster and breathe deeper. And so what we start to experience is these patients' respiratory rate and depth goes up. And what happens is they experience something called tachypnea. And so sometimes tachypnea can be a pretty common feature if a patient is acidotic enough. All right, so watch out for that. The other thing is that as the pH is really low and there's lots of protons, the thing that happens here is that protons and potassium get exchanged across cells. They're both positively charged ions and they have to move kind of to maintain electroneutrality of the cell. So oftentimes protons will move in the direction into the cell, and cells are bags of potassium, so potassium moves out of the cell. If there's lots of protons that are present here, what will happen is they'll move into the cell pretty heavily, and then potassium will move out of the cell. So as many protons that come in, also potassium will go out. So this pump will become super activated. And so what will happen is lots and lots of potassium will leave, and so potassium will start ending up in the bloodstream at a higher amount. And so what we start to experience is that these patients have a higher risk of hyperkalemia. So that's another thing that you want to watch out for is acidosis increases the risk of tachypnea, hyperkalemia, and in some cases it even can cause, if it's really, really severe, it can cause the contraction of the heart to reduce and it can cause the vessels to dilate. So it can cause hypotension. And so these are things I want you to think about, but I think the biggest one here is the hyperkalemia. All right, with that being said, so with metabolic acidosis, one of the biggest things is I really want to watch that pH and I want to make sure that it doesn't get too low, especially when it gets less than 7.2. As it starts to experience a drop less than 7.2, I start to see potential complications like this arise. The next common thing is hyperkalemia. So as the GFR starts to drop, a patient's ability to filter off potassium reduces. So blood's supposed to go into the glomerulus, you're supposed to filter that potassium off and not have the potassium that's leaving the glomerulus be heavy. But because we're experiencing this drop off in the GFR, we'll start to see potassium go on the rise. As potassium goes on the rise, it has a very strong effect on the heart. It can increase the blockade, so it actually can cause suppression of the AV node. And so one thing that we can experience in these patients is they can have an increased risk of what's called AV blocks. So this could be first degree blocks, second degree Mobitz 1, Mobitz 2, and even third degree blocks. So that's one potential thing. The other thing is it can cause these ECG changes that sometimes are very high yield for your boards. And I think it's also really important to be able to recognize these things if you have a patient who's experiencing hyperkalemia. Now, what are these potential things that we could see? Well, in a perfect world, it follows this pattern, a 1, 2, 3, 4 pattern. Let me explain what I mean. So 1 is, I want you to remember, is going up. This is oftentimes when patients experience peak T waves. So peak T waves are oftentimes a very common feature of a patient potentially having hyperkalemia. The next thing is 2, so then we're going to go back to the left. And what we're going to do is I want you to think about 2 as though we're going back to the PR interval. And what's happening is the PR interval is getting longer. So now look at my PR interval here. It's longer. So when you start to experience an increase in the PR interval, that could also be due to the hyperkalemia. Now here's what's interesting. When the PR intervals get longer and longer, what do you start to experience? Potentially increased risk of AV blocks, right? Especially first degree and second degree Mobitz 1. The next thing is that you start to notice as we go down on the P wave will disappear. Now look, we went from a long PR interval to dropping of the P wave. So now I have no P wave. If I have no P wave, what is that kind of consistent with? If I drop P waves, that could be second degree Mobitz 2, that could even be third degree. And so we start to see an absent P wave. The last thing that starts to become very concerning is as we go back to the right, I'm going to widen the QRS complex. And as I widen the QRS complex, what we start to see here is, again, increased risk of these third degree blocks, but also it increases the risk of something very, very, very scary. And what I mean by that is it can lead to this patient breaking down this wide QRS into what's called a sine wave, and that can increase the risk of ventricular fibrillation, so they can go into cardiac arrest. And so that's why it's important to be able to identify the EKG changes. Not everything progresses in a perfect way as the potassium gets higher, but in a perfect world, it would go in this direction, and that increases the ominous findings of a patient going into cardiac arrest. Oftentimes, they may just go directly into cardiac arrest, but it is important to recognize these things. All right, so this is really concerning whenever potassium starts to get really high. This is oftentimes an indication to really start considering initiation of dialysis, especially if they're not responding well to treatment. Okay, the next thing is hypervolemia. So as patients start to experience, again, this drop off in the GFR, one of the things is that we're supposed to take sodium and water and filter these puppies out. But if we can't filter out that sodium and we can't filter out that water because the GFR just, sorry, it sucks, then what's going to happen? I'm going to have a buildup in sodium and I'm going to have a buildup in water. The problem with this is when you build up sodium, but more so, you actually hold on to a lot of water. I'd say more water than you hold on to sodium. The problem with this is that this really increases the risk of what's called hypervolemia, right? So your blood volume, your actual circulatory blood volume could potentially go up. Problem is that sometimes these patients are also at high risk of that fluid leaking into interstitial spaces or into cavities. And so what happens is this fluid doesn't always stay in the bloodstream. And so sometimes it can leak into the pulmonary, from the pulmonary capillaries into the alveoli, the interstitial spaces, or even it can leak into these areas here, like the pleural cavities. And so it starts leaking into these cavities or these interstitial spaces. Patients can start getting what's called pulmonary edema, is a really common feature. And the second one is pleural effusions. And so just watch out. I'd say the biggest thing is to watch out for pulmonary edema. And you can see this on chest x-ray, right? So this could be a chest x-ray finding. Or it may cause symptoms like dyspnea or hypoxia. And so it's important to be considering these things. If a patient says, hey, I'm really short of breath, or when I auscultate their lungs, I see that they have crackles or rails on auscultation, it could be indicative of pulmonary edema. The other thing is look at these legs. Are they like, fucking tree trunks and they look swollen as all crap? This could be indicative of the fluid backing up into the inferior vena cava and leaking out into the veins in the interstitial spaces and causing pedal edema. Oftentimes with pedal edema, this causes pitting. And so you want to watch out for any kind of pitting where you press down, and when you press down, it kind of keeps that kind of divot in there. this is oftentimes pretty common with hypervolemia, especially from CKD. The last thing is when the blood kind of gets into your vascular system, imagine here I have all this volume that's sitting in my vascular system. And even if you have a good heart, if you're really, really filling up their pipes and their heart, it may be difficult for them to maintain that amount of volume to get out of their heart. And so sometimes if this isn't enough, the fluid can back up. We talked about one of them. If it backs up into the left side, they can get pulmonary edema. If it backs up into the right side, they could get a couple different features. One is they could get jugular venous distension. And so watch out for jugular venous distension. The other thing is if it backs up via the inferior vena cava, they could get things like ascites and pedal edema. So I'd also watch out for that. The other thing is, if you expand their volume within their circulation, you're having these guys pump out large volumes, what's going to happen to their blood pressure? Oftentimes, this contributes to the patients having higher blood pressures too, because they're hypervolemic. So I would watch out for that. High blood pressure, ascites, jugular venous distension, pitting edema, pulmonary edema. The other thing is if you have more water than you do sodium, what also can that do? It can cause hyponatremia. So watch out for hyponatremia. That could be a sign of they're very, very volume overloaded. All right. Really watch out for that. Listen to the patient's symptoms, but one of the big things I would watch out for is their weight. Oftentimes, they may not have any of these symptoms, but their weight may be going up and up and up and up. So a little tip that I would add for you guys to remember is to monitor their weights. So monitor daily weights. We suggest this in patients who have heart failure because they can also have this kind of same concept. And I would also suggest this to patients who have chronic kidney disease, especially if they're in the later stages. All right. The next concept is uremia. Now, uremia can be pretty bad. Uremia is not defined as the level of BUN or other waste products in the bloodstream. That's azotemia. Uremia is when the waste products that are building up in the bloodstream are causing clinical manifestations and complications. What does that mean? All right, let's use BUN because oftentimes that's the one that we measure and we look at and we oftentimes consider, but it's not the only waste product. A lot of these other uremic toxins could be involved, but for simplicity's sake, oftentimes we look at the urea or the BUN, the blood urea nitrogen. As your GFR starts to go down, especially around CKD 4 or 5, what we notice is that the BUN starts going up and up and up, and that's called azotemia. When azotemia is present, all right, it oftentimes can be asymptomatic and you don't have any problems. But when it starts to cause things like vague symptoms, like maybe some nausea, anorexia, vomiting, then we're kind of getting into the uremic area. But where it's really concerning and a very strong indication to know because you need to dialyze these patients is when they start to experience some really scary complications. One is it could hit the brain tissue. The second one is it can hit the heart. And the third one is it can affect the platelets. So let's say the first thing it does to the brain tissue, it can actually cause some degree of changes in the osmotic shifting. And when it does that, it actually can cause the patients to become super lethargic and confused. And so one of the biggest things is they experience what's called an altered mental status, AMS, which can go from lethargy to confused, and sometimes they can even go into a coma. And so that's a pretty scary thing to think about, right? The other thing is it can cause a weird encephalopathic kind of feature where if you kind of take and extend their hands, they'll have this flapping tremor. Take a look at this like GIF here. All right, so we've seen that. This is another concerning sign. So if you see patients who have acidosis and an altered mental status, I definitely start being concerned that the actual uremia is causing something that we refer to as encephalopathy. So encephalopathy is kind of an overarching theme of, it's kind of an umbrella term, if you will, that it's an altered mental status. They may even have features of like negative myoclonus or asterixis. We want to figure out why. It could be due to the elevated BUN. All right. That's the kind of finding here that I want you guys to think about. The next one is it can cause pericarditis. So it loves to hit the pericardium. And when it hits the pericardium, it causes inflammation of the pericardium. As to why, I'm not exactly sure, but it does like to cause inflammation of the pericardial tissue. When you cause inflammation of the pericardial tissue, the first thing that's going to happen is you're going to have that characteristic pericardial chest pain. The pain that oftentimes can be positional, so it kind of maybe decreases whenever you're kind of like leaning forward potentially, and then it also radiates to the trapezius, right? That's oftentimes the classic finding of pericardial chest pain. So they're going to have that chest pain. The other thing is that if you have inflammation and a lot of fluid that's accumulating within the kind of pericardial cavity, they can get friction rubs and they can get pericardial effusions. And so watch out for effusions and friction rubs. Oftentimes what they're going to do on the exam is they're going to say that, oh, we have a patient who has, chronic kidney disease stage 5, and you're auscultating their heart and their lungs, and you notice like kind of like a friction rub present. What complication could they be experiencing? That could be uremic pericarditis. Or is this an indication to initiate dialysis? And you would say yes. The other thing is if you get an echo and you see the presence of a pericardial effusion, that could also be indicative as well. And the last thing is to look for ECG changes. Just like in patients who have hyperkalemia, watch out for ECG changes that are present in pericarditis. These ECG changes are kind of like concerning because they kind of can scare you, because you'll see ST elevation diffusely and PR segment depression. And so that's what I would be watching out for, is watch out for diffuse ST segment elevation and PR segment depression. This could be indicative of pericarditis. So if you have at least 2 or 3 or 4 out of these things, it could be indicative of uremic pericarditis. All right, so that's one thing. Oh, son of a gun. It can initiate encephalopathy, pericarditis, and the second thing is it can indicate platelet dysfunction. And so I like to just say platelet dysfunction, but oftentimes this can present with bleeding. It's not all the time. It just means that they're at high risk of bleeding. Let me explain why. Here I have some platelets. These platelets, normally, if there's a break in the vessel wall, what do? They go and they stick to that actual break, right? And they form what's called a primary hemostatic plug or a platelet plug, right? But in patients who have uremia, guess what happens? This is inhibited. The concept behind this is that they may not be excreting things like von Willebrand factor. They may not be excreting things like factor 7. They may not be excreting things like ADP and serotonin, thromboxane A2, all the things that are supposed to help the platelets to stick and to aggregate other platelets to the area. And that is a problem. So if this starts to happen and I can't do this, and I develop a break in the vessel wall from a procedure or whatever it may be, an excoriation of sorts, this patient is very, very prone to bleeding. And so oftentimes, one of the concerning features here is bleeding. Right? This can present in a bunch of different ways. One is it could cause like epistaxis. Another one is it can cause gingival bleeding or mucocutaneous bleeding, GI bleeding. One of the biggest things is we worry about doing procedures on these patients because they're at high risk of bleeding as well. And so this is really important. The reason why I'm kind of really emphasizing a lot of this stuff is that if you see these things, you got to dialyze your patient. The other thing is we have particular treatments specifically for the platelet dysfunction as well, that we try to reduce the risk of bleeding in these patients if we're going to perform procedures or we experience bleeding and we're suspecting that they have uremic bleeding, all right? All right, so these are the big complications that are really important and can indicate a patient who need dialysis very, very soon. All right, the next concept here is secondary hypertension. So this is also a really bad one. So we see this a lot in renal vascular diseases, things like polycystic kidney disease. We see it in things like renal artery stenosis, and it's very common in chronic kidney disease. Oftentimes, renal vascular disease is the most common cause of secondary hypertension. So one of the big concepts behind it is actually pretty cool. I'm not gonna lie, the kidneys are they're a fascinating organ. Their autoregulatory mechanisms are pretty kind of interesting. So whenever we talk about patients who have chronic kidney disease, that again, they lose that GFR. That ability to filter things across the kidneys is lost. And so when this starts to happen and they start to have that drop off in the GFR, there's some special cells. They're called these macula densa cells. And so these macula densa cells are near like the distal tubule. And so they respond to like the concentration of sodium chloride, which is kind of applicable to the GFR. And so when they sense, oh, it's kind of lower, hey, the GFR is probably lower, we should probably tell the JG cells they're not doing their job and they got to do a better job. And so what they do is they tell the JG cells, hey, JG cells, what we've noticed is that the GFR is kind of low. We're sensing that. Can you go ahead and do your job and get the blood pressure to pump up and put more blood going into the glomerulus? That may help. So JG cells do that. And so what they do is they increase their production of renin. Right? So they start pumping this out. When they pump out renin and you get these increased levels of renin, you know what renin does? It tells angiotensinogen, it converts it into what's called angiotensin 1. Angiotensin 1 then in the presence of what's called angiotensin converting enzyme leads to the formation of what's called angiotensin 2. Now, what happens is as I make more of these, as I make more of this angiotensin 2 and this levels start kind of going up, guess what they do? Angiotensin 2 then goes and it acts on these angiotensin 2 receptors on our arterioles. And what it does is it actually stimulates in a very potent vasoconstriction. Now, when I cause vasoconstriction, I mean it's a potent vasoconstriction. They squeeze the heck out of these vessels. The resistance goes up like crazy, and as a response, the blood pressure follows that. So if the resistance goes up, the diameter goes down, and then guess what? That blood pressure going to shoot up. That's how the blood pressure goes up. The second thing here is that angiotensin II also stimulates an increase in the production of two hormones. One is ADH, which is released from the posterior pituitary. And the other one is aldosterone, which is released from the adrenal cortex, right? And it's cool how they do this because whenever these are released, they say, okay, guys, we know the kidney's a little jacked up, but do the best you can. Go down to it and tell ADH, tell the cortical, the collecting ducts to increase water reabsorption. Aldosterone, go there and tell them to reabsorb sodium. And so this one affects sodium, and this one affects water. Right? So that's the whole goal, is I want to increase sodium and I want to increase water. That's the goal, right? And so whenever blood is coming out of the kidney, then after we reabsorb it, what should it be high in? It should be high in sodium and high in water. If we do that, I'm theoretically expanding my blood volume. And so the blood volume should go up. If my blood volume goes up enough that my vasculature is kind of having to respond to this, what's going to happen to the blood pressure? It's going to increase the blood pressure. See how blood pressure goes up in secondary hypertension from fluid retention, from hyperaldosteronism and ADH, as well as this is the more potent mechanism, the vasoconstrictor response. You know why this is important? When we treat patients who have CKD, the most potent drugs are things that reduce angiotensin II, because that reduces their blood pressure. And I'll talk a little bit later, it also reduces proteinuria, which can kind of reduce the progression of the disease, which is kind of cool. All right, my friends, we have hit secondary hypertension. We move on to the next one, anemia of chronic kidney disease. So in patients who have chronic kidney disease, what we start to experience with anemia is kind of interesting, right? It has not necessarily so much to do with the GFR. It's usually as the disease progresses, you lose nephrons. Now, some of the literature says that it's the proximal convoluted tubular cells. Some say it's the cells around it. Either way, it's a part of the nephron. As there's injury to the tissue of the proximal tubular cells or the interstitium, what happens is they lose their capacity to make a hormone. You know what that hormone is? One of them is called erythropoietin. So erythropoietin is one really big one that is supposed to be released from these peritubular cells, and if it is not, there's a problem. The other thing is, when there's a lot of inflammation of the kidney, these inflammatory cytokines, what they actually are able to do is when there's chronic inflammation, especially in the presence of like a little bit of interleukin-1 and maybe even a little bit of interleukin-6, which you get with chronic kidney disease. It's a chronic inflammatory disease, right? When these kind of are slow and ketteringly up, then what they do is they tell the liver, and the liver responds to this. And the liver says, oh, okay, all right, you're gonna do this. What I'll do is I'm gonna increase the production of kind of like one of these proteins. It's kind of like an acute phase reactant protein. It's called hepcidin. And hepcidin is kind of helpful because it kind of controls a little bit more of our iron storages. And here's what I'm leading to this. With inflammation from chronic damage to the actual nephron and reduction of EPO, what this does is all this is going to lead to anemia. Let me explain why. Hepcidin is really cool because it kind of like controls the macrophages and controls a very important or ferro-important protein on the intestines. And so what it's supposed to do is it's supposed to help with the absorption of iron across the GIT, and it's also supposed to control the release of iron from the macrophages. If the hepcidin levels are high, it shuts down the release of iron from the macrophages and shuts down the ferroportin channel, and you can't absorb iron. Either way, the iron levels start to drop. If iron levels start to drop, guess what iron is really, really important for? Red blood cell production, baby. And so what will happen to the number of red blood cells? They will start to drop because we're not going to have the necessary kind of like element here that is needed to make red blood cells. The other concept here is erythropoietin is supposed to stimulate the erythroblasts to start going through the maturation process and make red blood cells. And so if I don't have erythropoietin, I decrease the production of red blood cells. This is where patients start to experience things like anemia. And we oftentimes look at this whenever the hemoglobin and the hematocrit, which is representative of the number of red blood cells, really starts to plummet. And the number that we don't like is usually less than 10. As we get less than 10, patients can start to experience symptoms like fatigue and pallor and things to that effect, and even palpitations. And so it is important to be able to recognize this, but what I really want you to know is that anemia of chronic kidney disease is not always just due to a reduction in erythropoietin. It oftentimes is due to iron deficiency as well, and it's really important to make sure that you keep an eye on that. Okay. The next component here, this is a heavy one. And believe it or not, we kind of talked about this a couple times in calcium disorders. We talked about it in the parathyroid disorders in the endocrine section. We're going to hit it again. You're never going to forget parathyroid disorders ever again. From hyperparathyroidism is another really big thing in chronic kidney disease. The concept behind this is actually kind of similar in both of them. Let me explain. In both of these, in patients who have chronic kidney disease, they lose the filtering capacity, right? They lose their natural GFR. And so what happens is they end up with what's called high levels of phosphate. All right, so both of these, secondary and tertiary, we're just going to compare back and forth. Both of them will have elevated levels of phosphate, right? And that is because they lose the filtering capacity. The GFR sucks, this increases. You can't filter it out. The other concept is the tubular cells. The proximal tubular cells are supposed to increase the expression of alpha-1 hydroxylase. What do you decrease whenever you damage those cells? Alpha-1 hydroxylase. So what starts to go down as a result of that decrease in alpha-1 hydroxylase? The formation of active vitamin D. So vitamin D is also deficient in both of these. All right, well, Zach, I'm really struggling to see where the difference is. The next concept is that both of these contribute, because phosphate binds up the calcium and decreases the free calcium. Decrease vitamin D, you don't absorb vitamin D across the gut. What happens to the calcium levels in the bloodstream? Goes down. They end up hypocalcemia. What does hypocalcemia do to the parathyroid? Tells it, hey, please make more of that parathyroid. Because the reason why is I need you to go and kind of take calcium from the bone, from the kidneys, from increasing more vitamin D, right? Problem is it's never enough to bring the calcium up. So in secondary, they have high phosphate, low vitamin D, low calcium, high PTH. All of these things lead to things that we'll talk about over here. The difference is that secondary hyperparathyroidism, whenever the chronic kidney disease continues. So let's say that there is a progression, so a worsening in their CKD over time, and they just don't get any better, they go to tertiary. And this is, again, with progression of the disease. So what happens is, same thing. This phosphate binds the calcium, reduces the free, less vitamin D, less absorption of calcium, so they end up with hypocalcemia, just like in secondary. The difference here is that low calcium tells the actual parathyroid to make more PTH, right? Same thing, same concept. But it's so repetitive that what happens is you get an increase in hyperplasia and an increase in autonomy. You're like, okay, Zach, what the heck are you talking about here? From this calcium constantly stimulating the PTH, it increases hyperplasia, makes them puppies thick. You can get some thick parathyroids. Look at these puppies. Look at the cheeks on these, right? The next one, and it's also going to make it have autonomy. When I give a thing autonomy, I give it the ability to do things on its own. Now, this thing gains the capacity where it has the ability to make a lot of PTH and it's able to do it on its own. Guess what happens? Oh, baby. The PTH goes up like crazy. And when that PTH goes up, it then gains the capacity to then increase the calcium levels in the blood because it then chews through the bone. It really works on the kidneys as hard as it possibly can, but mainly it works on the bone. And this is what is the difference here. Tertiary is high phosphate, low vitamin D, high PTH, high calcium. Secondary is high phosphate, low vitamin D, low calcium, high PTH. At this point here, the patient is starting to experience more bone disease and more complications. What are those things? As a patient goes from secondary to tertiary, we start to experience a lot of work on the bones. It's actually kind of sad. I've seen this disease once, and I'm not going to lie, it's a very, very, very sad disease. And when they start to have this kind of effect where the PTH is just kind of like through the roof, what happens is that PTH, it loves the osteoclast. If your kidneys can't reabsorb calcium because they're damaged and they can't make vitamin D, who are you going to tap into? The bones. And so unfortunately, it uses the osteoclast as the main way. And so when it hits these bones, it hits those osteoclasts, and it causes the osteoclasts to increase their bone resorption, right? And so one of the concepts here is that you're going to start resorbing a lot of bone, right? Because your hopeful goal is that if you increase your bone resorption, you'll chew through the bone and you'll release and kind of liberate calcium from the bone, because you're trying to increase the calcium level so you can stop the PTH from going up. Problem is, as I chew through the bones, I end up with an increased risk of different types of diseases. One is called osteitis, cystica, fibrosa. This is a nasty disease where they get so many different types of chewed up cysts and lesions within their actual bones. Take a look at this. The other thing is you start making the bone more porous. So they can start off with osteopenia and it can go full blown into osteoporosis. Now, what's the problem with having some really, really weak bones? Do you know what that is? You go ahead and maybe you fall or you step too wrong and you can end up with a pathological fracture, especially the spine. It's a very, very sensitive area where that can happen. And so they can end up with pathological fractures. And so oftentimes we say that they can experience what's called bone pain. The pain is usually due to a lot of the fractures and maybe even the chewing of the bone via the osteitis, cystica, fibrosa. And so these are really, really big things that you want to think about for the actual exam. The last one, and this is the thing that I've seen, and it's actually really, really sad and terrifying, is calciphylaxis. In calciphylaxis, what happens is the patient's phosphates, right, is really, really high. And I usually would say that we see this more so in tertiary as compared to secondary. But the phosphates are really high. And the reason why I say we see it probably more likely in tertiary is because oftentimes the calcium is high. What happens is the phosphates and the calcium, they complex. And when they complex, they deposit into the vessels. And what they do is they start causing calcification of the vessels. Now, as they calcify these vessels, they make the vessels harder, and they also start kind of narrowing the lumen. So now look at this. I'm going to take the lumen and I'm going to make it more narrow because I'm calcifying it, making it a little bit more difficult there. With that happening, so if I cause vascular calcification, what that does is that narrows the lumen of the vessel. As I start to do that, I cause ischemia to the tissue which this actual vessel serves. Question is which vessels are we most commonly affecting? It oftentimes most affects the dermal and subcutaneous tissues. All right, so it often affects the most commonly is the dermis and the sub-Q tissue. And so what happens is if you start causing ischemia to the dermis and the sub-Q tissue, guess what starts to happen? You get some, oh my gosh, it's so sad. You get these painful, and I mean extremely painful, ulcers of the skin. To give you an idea of what this looks like, take a look at this. So this is a really important thing. So patients who have hyperphosphatemia, hypercalcemia, and I also see this a lot in patients who also have warfarin use. So if they use warfarin, this also kind of increases the risk of calciphylaxis as well. But this is the concept. So when a patient has CKD, what you're looking for is risk of calciphylaxis. You're also looking for bone lesions. But the biggest thing is keep an eye on their phosphate, their vitamin D, their calcium, and their PTH levels. Because where they are in that stage predisposes them to these potential complications. All right? The last thing, and I'm going to kind of quickly go through this one, is hyperlipidemia. We don't have a strong understanding of as to how this actually happens, but what we do know is that in patients who have CKD, what happens is, I told you before, is they kind of start dumping albumin into their urine, right? So they end up what's called a lot of albumin in their urine, right? That's kind of the biggest thing. So I'm going to dump a lot of albumin here. As I dump albumin into the urine, this can cause a lot of different things. One is the things that leave the actual kidney now is the albumin is low, right? There's also a lot of inflammatory mediators that also is kind of occurring because of this. But here's the one thing that we kind of do know is that albumin, when it's low, it tells the liver. The liver responds. Liver says, okay, albumin's low, I'm going to make more proteins. And so what it does, it tries to make more proteins. The only thing is it makes lipoproteins as well, because that's a protein. And so it increases the production of things like LDL and VLDL, and these, particularly the LDL, predisposes these patients to getting what's called atherosclerosis. So now they end up getting plaques developing within their vessel walls. So they can get what's called accelerated atherosclerosis. But again, I really want you guys to understand, this is not the only mechanisms. There's also thoughts that albumin, the albuminuria increases reactive oxygen species. It increases kind of like endothelial dysfunction. But either way, this atherosclerosis is super accelerated. If this happens, the concept behind this is that I increase the risk of atherosclerotic cardiovascular diseases, which can lead to death, which is the most common cause of death in patients that have CKD. So increased risk of atherosclerotic cardiovascular disease. What does that look like? If it affects the legs, PAD. If it affects the heart, CAD or MI, which is oftentimes the most common cause. And if it affects the carotids or some of the basilar vessels, this can lead to TIA, CVA. So it's really, really important to be able to recognize these things. But again, I just want to stress, I just don't want to add it in because I don't want you guys to get bogged down. The albuminuria is not just because of this mechanism that causes accelerated, it causes endothelial dysfunction and it causes a lot of inflammation. Now that we know this, we've hit a ton of complications that you can experience in CKD. The thing I want you to do is, okay, say if a patient comes in with CKD, how do I really figure out if they have CKD? And if they do, what stage is it so that I can really monitor these complications? And how do I determine if their risk of cardiovascular disease is up? And then lastly, how do I really figure out the cause so that I can address that? Let's move into that next. All right, my friends, let's now move on to the diagnostic approach to chronic kidney disease. So how do we really determine this? Well, the best thing is to get a renal function panel, right? So if a patient has what you suspect to be chronic kidney disease, how do I really diagnose it? It's based off that GFR primarily, right? We got to be really particular though. If the GFR is less than 60, that's really where we can kind of talk about chronic kidney disease, especially if it's persistently less than 60 for greater than or equal to 3 months. So if it is, we can diagnose the stage of CKD right then and there based upon the GFR. We don't need anything else. So for example, let's say that the GFR is 45 to 59. Then that's definitely CKD, but we can say it's CKD 3A. If it's 30 to 44, it's CKD 3B. If it's 15 to 29, it's CKD 4. And then if it's less than 15, it's CKD 5 or end-stage renal disease. Now you're probably like, what about CKD 2 and CKD 1, Zach? Well, CKD 2, technically you could say in this scenario that it's 60 to 89 and CKD 1 is technically greater than 90. The problem with that is that we can't only base it on GFR. We then need something else to show injury to the kidney. That's where albumin comes in, or renal ultrasounds, or urinalysis comes in, and we'll get to that. But again, to really emphasize this, if the GFR is less than 60, it has to be persistent. So in other words, let's say I have John Doe's labs, and I'm looking at it month 1, month 2, month 3, month 4. I'm expecting to see this be low persistently, not just a one-time low GFR, all right? And oftentimes we'll see the creatinine, the BUN also be elevated. But again, the key thing here is, what do you notice? 58, 52, 50, 48, all of it is kind of falling within this range, right? It's all falling above 45 and all kind of below 59. So this person has CKD 3A based off their GFR. All right. And we can say that because it's been persistent for greater than 3 months, and that's how we would diagnose it. But if a patient has a GFR greater than 60, we can't diagnose CKD 1 or 2 based upon the GFR alone. We technically need other evidence to show that there's kidney injury. That's where I really think urine, albumin, and creatinine ratio comes in. That's why I stressed it in the beginning, because albumin being lost is a sign of kidney disease. When albumin's lost and you have it in the urine, it's called albuminuria. This is also really great in determining if they have kidney disease, chronic kidney disease, but it also determines prognosis. As we talked about, it has a high risk of cardiovascular disease-related death. The concept here is that if the patient has the ratio of less than 30, it's mild, it's not too bad, it's a little elevated, but if it's 30 to 300, that's actually microalbuminuria, that's a little bit more heavy. But if it's greater than 300, that is macroalbuminuria, and that's pretty heavy. And that's really, really important. So if they have albuminuria, that could be a sign of chronic kidney disease, especially if it's really, really elevated. And this is also really important because when we talk about this, we know that this is associated with chronic nephron injury. But what we really need to remember is this, and this is really important. It can present before a drop in the GFR. So patients can have albuminuria before we see them having a GFR less than 60. That's why it's important to know this. Now, the other concept here is that what's really high yield is that albuminuria, the level of it, portends a poor prognosis. So if it's higher, poor prognosis. And the reason why is because of risk of cardiovascular disease and those related deaths. Could be due to endothelial dysfunction, could be the hypothesis that we talked about, the VLDL and LDL that's being overproduced in response to the albumin that's being lost. Either way, we know it's associated with this. Now, another thing is we could get an ultrasound. I say this is okay. It's not as good as the urine albumin creatinine ratio, but I think it's always a part of a workup in a patient who has underlying kidney disease. What you'll see is some non-specific signs. So you may see that they look a little bit more hyperechoic, a little bit brighter, but the big thing is that the cortex really thinned out. And then the size of the kidneys are usually a little bit smaller. And this is just a sign that they're getting kind of fibrotic and they're losing some of their normal parenchyma. So this is usually a sign of chronic kidney disease. So I think that's a big thing to remember here. So if a patient has a GFR greater than 60, and I want to say that they have CKD2, maybe their GFR is like, 65. And I really want to make the diagnosis of CKD2, I kind of need other evidence, maybe some albuminuria or some imaging that shows that there's disease of the kidney. You can even sometimes do a sediment, so the urinalysis with microscopy, if you see a lot of broad waxy casts, that could also maybe show that there is chronic injury and disease of the kidneys, because that's not usually normal. All right. But that's the benefit of getting these extra tests to find other kidney injury. Now, the next thing that's also really important is that with the renal ultrasound, the reason why I think it's a great test to look at chronic kidney disease is not just this, but it also can find etiologies. Remember I told you polycystic kidney disease is maybe like the fourth most common cause of chronic kidney disease? If you get the ultrasound, you see these bilaterally enlarged kidneys with multiple cysts of variable sizes, and you don't really have any other alternatives. They don't have diabetes, they're normal A1C, good blood pressure, usually polycystic kidney disease has high blood pressure, but no true underlying chronic hypertension, and then no glomerulonephritis. So you could probably say it's polycystic kidney disease, right? The other thing is that if we kind of go a little bit further to figure out what the cause is, that's where I would get the things like A1C, get some normal blood pressure trends, and I would get a reurinalysis with microscopy. And if their A1C is elevated and they have chronic diabetes that they're not taking care of themselves, it's probably diabetic nephropathy. If their blood pressure is persistently elevated and they have normal A1C and no urinalysis findings that are suspicious, it's probably hypertensive related nephropathy. And then lastly, if they have a urinalysis that's really, rich in protein, and they have lots of hematuria with red blood cell casts, I could start thinking about glomerular disease. And that's where I would start potentially thinking about that, maybe needing to get a biopsy if I'm concerned. So this is kind of how I want you guys to think about chronic kidney disease. If it's less than 60, we can diagnose CKD based upon the GFR alone. If it's greater than 60, we need more evidence. We need to find evidence of kidney injury. That's where the albuminuria is coming in handy. That's where a renal ultrasound could potentially be handy, or a urinalysis with microscopy to show broad waxy casts. If you have those plus that GFR, then you may be able to make the diagnosis of CKD1, CKD2. All right. Once you've diagnosed it, try to figure out the underlying cause. Use your ultrasound. Do they have PCKD? Or do they have diabetes that's uncontrolled based on their A1C, persistently elevated high blood pressure that they're not compliant with their medications, or evidence of glomerulonephritis? All right, my friends, we've covered that. Let's now move on to the treatment. The big thing is treating complications. Do they have an acidosis? Less than 7.2, maybe some concurrent hyperkalemia? Give them bicarb. Do they have hyperkalemia? If they do, low potassium diet is usually first line. Give them loop diuretics if they're hypervolemic or potassium binding resin. That's the way to go. So let's say that we start off with the low potassium diet. Basically, you're trying to prevent hyperkalemia. So you try to make sure that the diet is low in potassium so they don't absorb as much potassium across the gut. The kidneys don't have to struggle to excrete enough of that potassium. So you can maintain a normal potassium level. If they start to get hyperkalemic, that's where you add on the loop diuretics. So giving a loop diuretic is going to get rid of volume, so if they're hypervolemic, which is common, and they have hyperkalemia. You're giving a loop diuretic to block that sodium-potassium 2-chloride reabsorption, and so then because of that, you're not going to get as much sodium in the medulla, you don't reabsorb water. So then you get rid of water that way, right? On top of that, if you block this, you get lots of sodium that gets to the distal tubule. Sodium goes in, potassium comes out. Because of that, I'm going to dump potassium and water into the urine. That's why this is really, really good for hyperkalemia and hypervolemia. The potassium binding resin, though, is also important because in this patient, you can do this if they're kind of like euvolemic. So you're giving them this thing because it's basically going to liberate the calcium and the sodium, bind the potassium, and then poop it out in the stool. So this is a great scenario for this. Just be careful when you're giving these things. You keep an eye on their EKG and you keep an eye on their potassium level. If a patient has hypervolemia, right, that's where sodium restriction and loop diuretics are great. Keep the sodium down because if your sodium in the diet's really low, you're not going to get as much absorbed. You're not going to have as much water retention, and you're going to kind of keep their blood volume at bay. All right. The other concept is if they do start to have hypervolemia, they have pulmonary edema, they have peripheral edema, they have hypertension, hyponatremia, that's where loop diuretics come into play. Because again, it's the same concept we talked about hyperkalemia. You're blocking this so that you can't push sodium into this medullary interstitium. You can't pull water out of the descending limb. So what happens? The water gets lost here. And so because of that, you're going to help eliminate that fluid from the body. So just keep an eye, though, on their daily weights and look to see if you're improving their edema. That's what I would do whenever you're treating these patients with the loop diuretics. All right. The next concept is desmopressin. You're like, wait, desmopressin, what the heck? We usually give this in patients who have uremic bleeding, especially before they get like a procedure of some sort. The concept is because, again, you're kind of trying to do what? Prevent them from bleeding because, again, your uremia is inhibiting the platelets from aggregating and forming a clot. You want to form a clot. So DDBP helps to stimulate these platelets to degranulate and release ADP and von Willebrand factor, right? And again, that's the concept. I want them to make these coagulation proteins and aggregator molecules to cause a clot. All right. The next thing is I like to give ACE inhibitors or ARBs to these patients. For what reason? Do they have hypertension? This is a really common cause of CKD, but it also is a common result of CKD. So again, you're basically trying to block the renin-angiotensin-aldosterone system. If I do that, I lower angiotensin 2, which lowers the constriction of the vessels and lowers the blood pressure, drops the aldosterone and ADH levels, so reduces the sodium and water reabsorption, dropping the blood volume and dropping the blood pressure. So this is really, really great. The other thing is that ACE inhibitors and ARBs are really good in proteinuria. Remember I told you albuminuria is associated with increased risk of cardiovascular disease and prognosis. If you reduce proteinuria, you reduce the progression of the disease. That's why these are really renal protective drugs. So the concept behind this is that you're giving these to block angiotensin 2. What does that do to the efferent arteriole? Causes it to vasodilate, so it doesn't constrict as much anymore. If it vasodilates, you reduce the pressure now. It's easier for blood to go in and come out. If the blood easily leaves, the pressure in the glomerulus drops. You don't filter as much as the albumin into that urine. And so that's the cool concept there, is that you don't dump albumin into the urine. Again, if you're giving these drugs for hypertension, keep an eye on their blood pressure and make sure that you're trying to get that thing better, getting it less than 130/80. If you're also giving it for the protein, keep an eye on their urine albumin creatinine ratio. The big thing to watch out for with ACE inhibitors and ARBs is that you do run the risk of potassium elevation because it's basically affecting aldosterone. It's causing hypoaldosteronism. And then also you're reducing the GFR. All right, so they can get a slight increased risk of an acute kidney injury with this drug. But again, you're trying to get that blood pressure down and you're trying to get the albumin in the urine lower. The next thing is, what about hyperparathyroidism? Low phosphate diets are usually the first thing that I do for prevention, then phosphate binders and sometimes calcitriol, and then lastly is calcium mimetics or a parathyroidectomy. We do this first line, this is second line, and then we do this if they have tertiary hyperparathyroidism. So let's go through this. Let's say that a patient does have hyperparathyroidism. I'm going to give them a low phosphate diet because I don't have them absorbing as much phosphate across the GIT, and therefore the kidneys don't have to struggle to be able to excrete that phosphate, and they can maintain a normal phosphate level. But if it doesn't work, then what I got to do is whenever they eat, I got to give them something to bind to that phosphate. So here's the drug, and what it's going to do is it's going to bind all of this phosphate and poop it out, which will maintain a normal phosphate levels. The next thing is I could treat the high PTH. The only reason I would give vitamin D was if the calcium is low and the vitamin D is low, because then you're giving it to increase calcium absorption and help to shut down the PTH production. So just remember, the only time to give the vitamin D is if the calcium and the vitamin D is low. All right, so that usually is going to be your secondary hyperparathyroidism. If we start moving into the tertiary, that's where I start asking the question, is cinacalcet going to be the best option for this patient if they're not a surgical candidate? What that does is calcium binds to this receptor that helps to say, oh, can you make PTH? If calcium is going to be really, really high, it tells the calcium receptor stop making PTH. If I give them a drug that acts like calcium, like cinacalcet, that'll bind to the receptor and say, hey, calcium's high, even though that's not the actual calcium, it's mimicking it. And that helps to reduce PTH production and also helps in this disease. And if that isn't the option, or if it doesn't work, then that's when I go and I'd say, let's cut the parathyroid out. And then sometimes we'll implant a little piece of that parathyroid into the forearm in case we need to remove it later, but to maintain some degree of parathyroid hormone production. All right. The next thing is if a patient has anemia, especially if the hemoglobin gets less than 10. This is the patient that we want to try maybe put them on erythropoietin, but also give them iron if they need it. The reason why is that sometimes these patients with hemodialysis, they need to get lots of transfusions. If I can give them erythropoietin, I could potentially reduce the need for blood transfusions. So that's why we kind of aim for giving this if it's less than 10. First thing that you have to do is get the iron up first. If they have low iron, you gotta treat that first. Improve their iron reserve. Maybe an iron transfusion, maybe iron pills of some sort, but get the iron up. Get it to the point where the ferritin is greater than 100, the transfer saturation is greater than 20%. We'll talk about this in iron deficiency anemia, but that's the goal. The reason why is when you do that, you're improving their iron levels to tell their bone marrow to make red blood cells. So you have enough of the iron storage to help make red blood cells. Then you come in and you say, okay, let me give them EPO. I have normal iron storage. Then I'm going to give them the EPO to improve their red blood cell production. But again, make sure you get the hemoglobin greater than 10. Get these levels up to make sure that the iron reserves are normal. And the whole goal of this is to reduce the need for packed red blood cell and transfusions that comes associated with dialysis. What else is really important? Chronic kidney disease, these kidneys are very sensitive, man. Their GFR is low. Their ability to filter not just waste products, but drugs. A lot of drugs are excreted renally. And so iodine is one of those. Be careful. If the patient has a GFR less than 60, avoid iodinated contrast unless it is absolutely necessary, because you run the risk of contrast-induced nephropathy. Avoid gadolinium contrast if their GFR is less than 30. These are patients that run the risk of nephrogenic systemic fibrosis. All right. And then lastly, always renally dose these medications. In other words, if you're giving a patient a medication for seizures or for diabetes or whatever it may be, make sure that you're adjusting the dose of it if it's renally cleared. Because if it's not, let's say that it's a drug that you're giving and it's supposed to be renally cleared. For example, let's say that you're giving them levetiracetam for seizures and you're giving them 1,000 milligrams of it. That's going to be sitting around in their circulation that predisposes them to more types of toxicity or adverse effects. All right. Again, this is always going to be the case when a patient has stage 3 KD or worse. You're running the risk of complications such as contrast-induced nephropathy, nephrogenic systemic fibrosis, and supertherapeutic drug levels. Let's say that we've done these treatments to try to treat the complications or prevent the progression of chronic kidney disease. How do we treat the patient who is, at this point, they're already too far gone? They're at the point of they're at end-stage renal disease. The GFR is less than 15. They have associated uremia, other complications that's starting to rise. We need to ask ourselves the question, do we need to dialyze this patient? There's two types. Hemodialysis is one. I say this is the most commonly utilized one within the kind of United States. What we do is we access their vascular system, take blood from their body, run it through this dialyzer, and this is going to allow for exchange to occur. We run an actual dialysate solution, a bath, against them to allow for us to maybe give them bicarb, remove out certain types of filtrates, and then whatever else is left, all that waste is going to get taken out via this kind of tube here. And then after the blood's been cleansed, we've removed any waste products, we've kind of given them bicarb or other kinds of things that they need, then we'll send it back to their body as cleaned and ready to go. Now, if we look in here, there's two types of ways that this can occur at this membrane. One is as blood runs through here, you can actually allow for diffusion. This is the most common one, the dialysate, right? Where you kind of give them a particular dialysis bath, which contains particular molecules. And what you're allowing for it to happen here is diffusion. So diffusion from high concentrations to low concentrations. So if there's kind of like not as much bicarb, the bicarb will rush in. If there's too much urea, too much potassium, too much water, that will diffuse out. But you're allowing for an equilibrium to occur between the dialyzer, between this kind of solution that's running out through the body into the blood, via their blood into this dialyzer, and you're trying to allow for this nice kind of equilibrium between the two. There's another one called convection. This is called ultrafiltration. And basically what you're allowing for it to happen here is things to only kind of move in one direction, which is out of the blood and into this kind of like used dialysis solution and out of the body. All right, this is something that we oftentimes will do as well, but it's usually a little bit more heavily utilized, I'd say, in continuous veno-venous hemofiltration. The other type of thing that we could utilize besides hemodialysis is peritoneal dialysis. So hemodialysis, we have to access their vascular system. Peritoneal dialysis, we access their peritoneum. And it's really cool. The peritoneum is kind of a really beautiful membrane that can act like a dialysis membrane. And what we have to do is we have to put a catheter in, and we kind of run this dialysis solution into their peritoneum. And we let it dwell there for a while. And after we let it dwell there for a while, the dialysis kind of membrane, if you will, which is the peritoneum, does everything we talked about. It allows for diffusion of waste products into the peritoneum, allows for maybe some of the bicarb or other types of molecules to get into the bloodstream. And then after they've done this for a certain amount of hours, usually overnight, then what we do is we drain the belly. And we get rid of all of that used dialysate solution, and then they're good for the day, and then they can dialyze themselves the next night. So this is another thing that's a little bit more convenient when you think about it, but it works the same concept. It's just in the sense of using a dialyzing machine, we're using the peritoneum as that dialyzing machine. So again, what are the reasons why we would dialyze a patient or perform any kind of hemodialysis or peritoneal dialysis? Is if they have refractory acidosis, refractory hyperkalemia, refractory hypervolemia, uremic complications, or their end-stage renal disease. This is usually the big one. All right. So again, we've treated them with bicarb, treated them with loop diuretics, potassium binding resins, loop diuretics, sodium restriction. They're starting to develop uremic complications, or they're at the point where we just need, they're at end stage, they're at CKD 5. We need to start getting them ready to get them ready for a transplant if they're a candidate. All right. That's when we would do this. Now, a little extra piece on here, because this is always tested in the exam. When we do hemodialysis, we have to access their vascular system. We can do that with a central venous catheter, an AV fistula, and an AV graft. How do you know which one to pick? An AV fistula is the preferred one for long-term use. It's going to have the best patency, lowest risk of infection, and but the only problem with this one is it takes a long time to mature. It may take up to 4 to 6 weeks for it to mature. So this one is going to be taking some time. So that's why whenever we tell a patient, hey, you need to get ready for dialysis, we have to gain access. You want to get an AV fistula started so that you have enough time for them to actually use that, because it takes some time to mature. An AV graft is one that you could do if you need a little bit less time, but the problem with this one is that it has a high risk of stenosis, graft failure, thrombosis, but it can mature a little bit quicker, so it's an alternative if you really need to. The last one is for urgent or emergent use, and this is central venous catheters. This is a catheter that we can do via tunneled or a non-tunneled line. So you tunnel it under the skin, or you just put it directly through the skin into the vascular system. And basically, this is going to act as your access point. But this is more for urgent or emergent use. This one is if you really kind of need to get there a little bit quicker than an AV fistula, but this is going to be the most preferred for long-term use. For peritoneal dialysis, we use this implanted peritoneal catheter. That's what's going to be left into this patient. And they're going to use this as their access point into the peritoneum. All right. Now, the timing of dialysis is also really important. This comes in with convenience and just aspects of life that are good for quality of life for the patient. So for this one, you access their vascular system. You unfortunately have to do this a couple times a week. So 3 times a week for a couple hours. Peritoneal dialysis, you do it daily, but they usually can do it at night. And that's a little bit more desirable. One of the big complications that can arise with hemodialysis that you have to tell your patient about is hypotension. And so whenever you're pulling, for example, if a patient's super hypervolemic and you're pulling volume off of them, this could drop their blood pressure. And so that's really important. If a patient is critically ill, that's where you may need to consider what's called continuous veno-venous hemofiltration. All right, that's one option. We also call it CRRT. Another thing that's also really important is dialysis disequilibrium syndrome. This is actually super fascinating. If you have a patient who maybe their BUN is just super high before you dialyze them, right? What's happening here is this is an osmogenic molecule. In other words, it's going to kind of pull water into the bloodstream, right? But the brain or tissue is very smart. It produces osmoles that help to maintain an equilibrium, right? So it adapts. All of a sudden, though, you dialyze them and get rid of this urea. When you do that, the urea drops. You have less osmogenic molecules in the bloodstream now. Where's the water going to go? Well, now, instead of it staying into the bloodstream, where's it going to go? Flushes right into the cells. Because now the concentration of the solute is less here, and it may be higher here. So water rushes in. These cells start swelling, and you get cerebral edema. So they can get headaches, they get nausea, vomiting, and sometimes it can even cause high intracranial pressure. The last thing is access complications. You want to be careful. If a patient has hemodialysis and you're accessing their vascular system, if you do central venous catheters, the reason why these are really not best long term is because they have a high risk of infection. And so you really want to be careful with that. The grafts are also a little bit more high risk of stenosis and kind of like clotting. And so you want to be careful with that as well. That's why AV fistula are going to maintain the most patency, the lowest risk of bacteremia, and they're going to kind of give you the best bang for your buck. The peritoneal dialysis is high risk of peritonitis. I mean, think about it. You have a catheter that is accessing your peritoneum. It is very common to get peritonitis with this one, and even hyperglycemia. But the big thing for this one is if you're looking at this, watch out for kind of abdominal pain, distension, rigidity, guarding, things like that that suggest that you may even have to take a sample off of the peritoneum fluid and then send it to see if the sag's kind of altered and see if they have any PMNs that are greater than 250. So that may initiate antibiotics that you have to dwell into there. The last thing that you have to think about is if a patient has to be on dialysis, you always want to ask the question, can I get this patient a kidney transplant? If they are a candidate, then you want to try to do your best to get a kidney transplant. All right, and so usually we'll do this in a patient who's on dialysis and a good candidate. And the question that sometimes you may get regarding this is, which side do you put it on? We like to put it on the left side. It's just because the renal vein's a little bit longer. And so that's one of the things that we'll do for transplanting these kidneys. Engineers, I really hope this made sense. I really hope that you guys liked it and learned a lot. And I just love you guys. Thank you guys. And as always, till next time.